Hello everybody, today we're going to be talking about enhancement in and around the brain. We're not going to discuss at length the mechanisms for enhancement or the full differential for each enhancement pattern, but we're going to look at both intra and extraaxial enhancement. We're going to talk about pachymeningeal versus leptomeningeal enhancement. We're going to look at and describe whether something's focal, regional, global, and whether it's smooth or nodular. For intraaxial enhancement, we want to look at if it's gyriform or cortical, if it's ring enhancing, irregular or smooth, whether it's open ring enhancement, or whether it's a classic cyst with a mural nodule. Always remember that one lesion versus multiple lesions can be helpful for determining etiology. Now, why do we want to do this? Because accurate perception and evaluation of the pattern of enhancement and location of enhancement will help us better determine the etiology. This talk does not focus on the individual entities. That will come later. We want to talk about and accurately describe the pattern. Here we have the majority of enhancement patterns that we will be talking about. Starting from the top left and going across, we have diffuse pachymeningeal enhancement of the dura arachnoid, or focal dural pachymeningeal enhancement. We have leptomeningeal enhancement of the p arachnoid, which runs along the surface of the brain throughout the arachnoid, into the sulci, into the cisterns, and along cranial nerves. We have cortical gyriform enhancement pattern, ring enhancement, some stylized surrounding vasogenic edema, open ring enhancement, and thick nodular ring enhancement with surrounding vasogenic edema, and the cyst with a mural nodule. We often see diffuse pachymeningeal enhancement in the setting of intracranial hypotension and the postoperative setting, but it can also be seen with calvareal metastatic disease, neurosarcoid, and extramedullary hematopoiesis. Here we have a case of diffuse pachymeningeal enhancement due to intracranial hypotension. The dura does not have a blood-brain barrier, of course, so it does normally enhance, but it should be thin and discontinuous. Here we have continuous, thick, abnormal enhancement of the pachymeninges, including the falx, the tentorium. This is far too much enhancement. Here's another case of intracranial hypotension. Again, we have diffuse thick pachymeningeal enhancement, and in this case we also have bilateral subdural collections. Whenever you have pachymeningeal enhancement, you have to evaluate for sagging of the brain downward, because normal CSF pressure keeps the brain floating within the calvarium. When pressure is low, the cisterns become effaced and the cerebellar tonsils herniate. So there should be a normal suprasellar cistern here, prepontine cistern, intrapeduncular cistern. All of this is effaced as the brain sags downward. The cerebellar tonsils are herniated through the foramen magnum. Now remember, when you see cerebellar tonsillar ectopia or herniation, don't just assume that this is a Chiari malformation. Always look to see if there's a mass pushing the cerebellar tonsils down, or if, as in this case, you have intracranial hypotension. So this would qualify as a pseudo-Chiari malformation. Not a true small posterior fossa, but sagging of the cerebellar tonsils due to intracranial hypotension. The next enhancement pattern we're going to talk about is the focal dural enhancement, which would be the classic example of a meningioma. It's important to also look at the adjacent calvarium for any hyperostosis, destruction of bone, and make sure you're dealing with a primary dural finding rather than a calvarial lesion with dural involvement. Here is our extraaxial, homogeneously enhancing mass with a broad dural attachment and with the classic dural tails. a meningioma. Now let's move on to the pia arachnoid leptomeningeal enhancement. This enhancement extends into the sulci and cisterns and often along cranial nerves. When you see this enhancement pattern, you want to think about abnormal vascularity or abnormal cells in the arachnoid space. Differentials for this can include infection, lymphoma, leukemia, metastatic disease, sarcoidosis, other entities such as Church-Weber and amyloid vasculopathy. Here we have a case of frontal sinusitis, which has spread intracranial with subdural empyema, peripherally enhancing subdural collection, leptomeningeal abnormal enhancement and abnormal signal on the flare throughout the left hemisphere, and parenchymal restricted diffusion. This would be a ring-enhancing lesion that we'll discuss later. But what we have here is subdural empyema, meningitis with leptomeningeal abnormal enhancement, and parenchymal abscess, all due to frontal sinusitis with spread of infection directly. Another case, we have abnormal leptomeningeal subarachnoid flare signal bilaterally, a little bit more in the dependent regions, abnormal restricted diffusion within the subarachnoid space, and again, abnormal leptomeningeal enhancement, which is quite thick. And this turns out to have been CSF leukemia. This is somewhat different than those last two cases. We have leptomeningeal enhancement most clearly within the posterior fossa along the cerebellar folia. Now, if we look very closely, we see nodular, abnormal enhancement. We call this sugar coating, and this is more commonly seen in metastatic disease. This happens to be a case of lung cancer, but can be seen in breast cancer and other metastatic disease to the leptomeningeal space. Enhancement of the cortex is commonly seen in the subacute phase of infarction, but can also be seen in encephalitis, radiation necrosis, and when focal and small, could be a neoplasm. This is cortical abnormal enhancement within the inferior aspect of the right frontal lobe, consistent with a subacute infarction. Next, let's talk about smooth ring enhancement. Ring enhancing masses have a classic differential diagnosis that you should know well. These include metastasis, abscesses, glioblastoma, subacute infarctions, contusions with hemorrhage, demyelination, radiation necrosis, and other more unusual causes. Here we have a case of multifocal ring-enhancing masses bilaterally with surrounding vasogenic edema. See how the cortex is largely spared, making this vasogenic edema. When we see lesions like this, our main differential is going to be metastatic disease and abscesses. And the key imaging sequence we're going to want to look at is our diffusion sequence. And so we see central restricted diffusion of the non-enhancing portions of the mass, consistent with abscess in this case. Here's an SWI sequence that also shows some susceptibility-related signal loss within that abscess. Now, if the enhancing portion of the mass was restricting, you would instead say that it was more likely to be a metastatic or primary neoplasm. Another ring-enhancing lesion in the juxtacortical white matter of the right frontal lobe. In a case where we also have more subtle sites of T2 prolongation in the juxtacortical white matter. This happens to be a younger female, and if we look at the sagittal sequence, we see radiating sites of white matter signal alteration from the undersurface of the corpus callosum, consistent with Dawson's fingers. This is a case of demyelination and multiple sclerosis. Speaking of demyelination, our next enhancement pattern is very classic for multiple sclerosis, and that's open ring enhancement. Here we have a case of ring enhancement, the right frontal lobe, And along the perimatricular region on the left, we have abnormal enhancement with corresponding signal abnormality. This is open ring enhancement in the case of demyelination. Another case, we have more mass-like T2 prolongation and abnormal enhancement, a little bit more irregular, but you can see an open ring, and this turns out to be tumefactive MS, or a more mass-like form of MS, which will evolve over time and should not be confused with neoplasm, but needs to be followed closely to make sure that this is not mistaken for what is actually a GBM. For enhancing mural nodules, we want to look at, is the lesion supratentorial or infratentorial, and what is the age of the patient? And is there a history of epilepsy? As all of these will help us differentiate the different types of classic lesions with an enhancing mural nodule. In a kid, we think about more of a pilocytic astrocytoma in the posterior fossa. In adults, we think about hemangioblastoma or metastatic disease, with hemangioblastomas having more vascular appearance and metastatic disease increasing in likelihood with increasing age. In the supratentorial brain, we think more about METs, gangliogliomas, pilocytic xanthorastrocytomas, and primary neoplasm, with gangliogliomas and pilocytic xanthorastrocytomas more often presenting in patients with seizures and epilepsy. Here we have a classic cyst with an enhancing mural nodule in a young person, and this turns out to be a pilocytic astrocytoma. Here we have a young adult with multifocal sites of abnormal enhancement, including a cyst with a mural nodule. And this happens to be a case of hemangioblastoma. Now, thick irregular enhancement is often seen in high-grade gliomas, such as glioblastoma, and here we have a case of glioblastoma, pre-contrast T1, post-contrast, irregular thick enhancement, areas of thin wall, and then thick nodular wall, surrounding T2 prolongation, best seen on this flare sequence, but also seen on T2. Predominantly a vasogenic pattern of T2 prolongation, and abnormal restricted diffusion within the enhancing portions, suggesting the high cellularity of the tumor. Now let's talk about a couple of special cases of abnormal enhancement. Here we have a case of brush-like enhancement involving the pons without mass effect, critically without mass effect, that's very important, and susceptibility related signal loss. This happens to be a capillary telangiectasia. It can be seen in other areas of the brain, but it's most classically seen in the pons. And here we have abnormal enhancement crossing the corpus callosum with mass effect and this intermediate T2 signal. This happens to be lymphoma, but this pattern of enhancement can also be seen in glioblastoma. And here we have geographic abnormal enhancement that includes both the pons, portion of the cerebellum, and the right temporal lobe. There's a straight line here of involvement. And so that's very unusual, and we haven't seen that in other cases. You could break this down to say, well, this is a ring-enhancing lesion, and here's a ring-enhancing lesion, and here's a ring-enhancing lesion. But you want to try to put everything together here. Here's a corresponding flare signal abnormality. Not a lot of mass effect. This turns out to have been a patient with head and neck cancer involving the maxilla, which was resected, and the patient had radiation therapy. And so this is radiation necrosis in the port of the radiation beam. So in summary, we talked about the various enhancing patterns. We talked about pachymeningeal enhancement, this diffuse form of it. We talked about focal pachymeningeal enhancement associated with a mass. We talked about leptomeningeal enhancement and how that would extend along the sulci and along cranial nerves. and throughout the cisterns. We talked about gyriform abnormal enhancement. We talked about some of the causes of ring enhancement, open ring enhancement, and more thick and nodular enhancement. Then we also talked about the classic cyst with a mural nodule. Thank you so much for your time.